Thank you everyone for coming. My name is Robert Steele and I'm a professor here in the Department of Philosophy at UNO and a member of the Medical Humanities Faculty as well. It is with pleasure that I can welcome you to our second ever lecture in our new Ethics of Medicine lecture series. Every last Thursday of the month at 7 p.m. Central, yours truly will be moderating an hour-long Zoom event featuring a scholar, or in this case, scholars in medical ethics who are applying their cutting-edge research to pressing contemporary problems. When it comes to being able to put on an event like this, there are a lot of people to thank, but I'd like to specifically thank the Ted Kooser Health Humanities Center for their financial support, as well as Courtney Kopetz of the College of Arts and Sciences for her invaluable administrative and technical support. For this talk, we are very excited to have Leah Pierson and Sam Doernberg here with us. Ms. Pierson and Mr. Doernberg are both currently medical students at Harvard Medical School, and Ms. Pierson is also a graduate student in the T.H. Chan School of Public Health. Before coming to Harvard, both completed fellowships in the bioethics department of the U.S. National Institutes of Health. Particularly for young physician scholars, they are already impressively well published. And the talk they will be giving us tonight is based in part on an article they put out recently in Annals of Internal Medicine, as well as work that they have currently ongoing. The topic they'll be addressing is where health profession students should fall in vaccine prioritization schemes. So for this event, the chat function has been disabled, so you won't be able to ask questions there. Instead, please feel free to enter any questions you have into the Q&A. You can enter questions whenever you like, and they'll then go into a queue where I'll be able to view them. After the presentation's finished, we'll then break for a Q&A session where I'll relay questions from the queue and probably a few of my own as well. So that's the format. And without wasting any more of anyone's time, I'll hand things over to Ms. Pierson and Mr. Doernberg.
All right, thank you, Robert, for that very kind introduction. Can you all see my slides okay? All right, so I'm Leah Pierson. I'm going to be talking first, and then we'll hear from Sam Doernberg. And tonight we're going to be speaking on an issue that affects us both personally, which is the question of whether health profession students ought to receive priority access to the COVID-19 vaccine. So this is going to be about a 25-minute talk, so there'll be plenty of time for discussion at the end, and we're really eager to hear your questions and your comments. So I'm going to start by making the case to you that this question about whether to prioritize medical students for vaccination and to prioritize other types of health profession students is occurring within the context of a broader question about what the role of health profession students is. And I think that if we can resolve that ambiguity, then that's going to help us answer this question of whether to prioritize health profession students for COVID vaccination. To get at answering that question, we're going to evaluate the frameworks that have been put forward by the CDC and by others, and we're going to see why they choose to prioritize healthcare workers. And we're going to evaluate whether those arguments for prioritizing healthcare workers similarly apply to health profession students. Sam's then going to present our recommendations. So if you disagree with those, feel free to take it up with him. And then we're going to discuss our conclusions and some implications and unresolved issues. And I want to emphasize what Robert said, which is that the paper that we're writing about this is under review, and it's very much a work in progress. And so we're very eager to hear your feedback and to hear your comments and anything that you think that we get wrong or that we miss. All right, so we think that this question of whether to prioritize health profession students for COVID vaccination reflects a broader uncertainty about what the role of health profession students is. And I'm going to try to illustrate this for you. So health profession students, like any other students, start their training as students. They sit in classrooms, they attend lectures, they read books, they do all the things that graduate students or high school students or any other type of student does. And by the end of their training, they're essentially acting as healthcare workers in clinical settings, providing patient care, functioning, of course, with supervision, but often autonomously doing a lot to support patients. And so we think this question of whether to prioritize health profession students is reflective of broader ambiguity, which is that students, at least in most parts of the world right now, are not being prioritized for COVID vaccination, right? So, we're not really vaccinating too many high schoolers who, are attending classes online, and we're not prioritizing graduate students or other types of students. And on the other end of the spectrum, healthcare providers, of course, are being prioritized for vaccination in most parts of the world. And the reason for this is they're working in clinical settings, they're at risk of transmitting COVID to patients. And so the question then of whether to prioritize health profession students involves answering this bigger question of, well, are health profession students more students, or are they more healthcare providers? And if we can figure out where on this spectrum health profession students fall, then that may give us insight into whether to prioritize them for vaccination. So to illustrate how I think that this ambiguity has sort of played out in the context of the COVID pandemic, I want to walk you through sort of what our experience has been as medical students, and how we've seen our own role evolve over time, and how there have been debates about how we ought to be treated. And while I'm going to highlight the example of medical students in particular, other fields have seen these exact same dynamics play out. And so we shouldn't think that these issues are unique to medical students. So in March of 2020, I was on my surgery clerkship. I came home at 7 p.m. from a long day at the hospital, and I arrive home to check my email, and I get this message. It says, "You will not be returning to the clinical setting next week." And little did I know that I actually wasn't going to be returning to the clinical setting for many, many years, because since then I've now become a Ph.D. student. So we were pulled somewhat abruptly out of the wards. And then eventually, a little later, people realized, you know what, health profession students actually can be really useful. They have skills, they have training, they have knowledge. Maybe we can put them to work. And so in many parts of the country, health profession students were graduated early. And people also felt conflicted about this. So I think, this quote from the New Yorker is pretty compelling. One doctor wrote that by graduating these students early, we're, quote, literally sending lambs to slaughter. And so there was this issue of, on the one hand, are health profession students like mini healthcare workers who can be super helpful? On the other hand, are they lambs who we should be protecting? The criticism also applied to current health profession students. So, for example, Harvard Medical School was criticized for asking its third-year students to work at a COVID recovery center with COVID patients. And there were this question of, well, if they're students, like, we don't pay them. In fact, they pay us to do this. But should we actually be treating them as healthcare workers? Should we be paying them? Should we be providing them with insurance? Sort of, what is their role? And then eventually, with a lot of these questions still pretty unresolved, people realize, this pandemic's not ending anytime soon. We need to get these guys back in training, because we need to have healthcare providers in the future who have good training. And so in a lot of places, students were sent back. In many parts of the country, the rates of COVID were actually higher when they went back to the wards than they had been when they were pulled off. And that was certainly true throughout the fall, when students in most places were actively involved in clinical care. And the prevalence of COVID at that time was much higher than it had been in the spring, when students were taken out of clinical context. So, these questions were in many cases not actually answered. And Sam and David, our co-author, and I took a stab at trying to provide some clarity about the role of medical students. And you guys can check out our article if you want to see a little bit more about that. And what we've done here is we've sort of taken some of those thoughts and lessons that we looked at there, and we've applied them to this specific question of COVID vaccine prioritization. So I think this ambiguity about the role of health profession students has led to this ambiguity in guidelines about whether to prioritize health profession students for vaccination. And I want to walk through one set of guidelines, although there are many. These are the CDC guidelines. And what they say is that there are approximately 21 million US healthcare workers, and we ought to prioritize these healthcare workers. The CDC also has an appendix where they define what a healthcare worker is, and they say, these healthcare personnel may include, but are not limited to, students and trainees. So there's this sort of open question of, do health profession students count? When do they count? How do they count? How many of them count? And I think it's interesting to note that the 21 million figure that they cite here as the number of healthcare workers in the US does not include health profession students. So these stats come from a place that doesn't count students, it just counts workers who are employed. And so interestingly, the CDC guidelines says, well, we can include health profession students, but their own number and their own, when they're putting these frameworks forward and they're considering how to prioritize people and how to allocate limited doses, does not include students. And so you might say, okay, well, there's only 750,000 health profession students in the US, is this really such a big deal? Like in the scheme of things, there aren't that many of them. But I think the issue is that there are many millions of health profession students worldwide, and particularly in low and middle income countries where access to vaccines is severely limited. It's really important to get these questions right and to figure out, okay, exactly who should we include? Because at the end of the day, each dose of this vaccine is, potentially a question of life or death. So I think we really want to make sure that we include the right people when we're prioritizing these doses. So I think somewhat unsurprisingly, the ambiguity about whether to include health profession students and the lack of guidance from the CDC has led to a mishmash of policies. And my goal here in highlighting some of these diverse policies is not to call out individual schools. I think, all of these schools are just doing their best to make hard decisions under challenging circumstances with very little guidance. And what I'm trying to illustrate to you is the need for some, clarity about what this policy actually is supposed to mean and who is supposed to be included. Because when we don't have clarity, we just get this mess of just different policies saying different things and different people being included in these prioritization schemes. So at Virginia Commonwealth University in December, what they decided was that they were not going to include health profession students in their vaccine prioritization scheme. And in fact, they were going to remove health profession students from clinical settings because they thought it was just too risky to have them working in those settings because, as we all know, in December and January, rates of COVID were extremely high. At the same time, VCU was vaccinating other healthcare workers, including healthcare workers who were working fully remotely. So you had health profession students getting taken out of clinical settings and not being vaccinated. And meanwhile, you had other healthcare workers who were already, sitting at home, doing work remotely, who were being prioritized for vaccines. And so students were understandably upset. One student wrote, quote, "I can't imagine trusting a Zoom trained physician." On the other end of the spectrum, schools like Duke were choosing to prioritize students who were working in high-risk settings like intensive care units and the emergency department. And at Yale, they were choosing to prioritize medical students by their last name. So if your last name was Zabar, you're in luck, you're getting a vaccine. If your last name's Adams, sorry, no vaccines for you right now. And I think most concerningly, at elite medical centers, many students were getting vaccinated who were at very, very low risk. So I talked to one student who said that she was a first-year medical student. She was taking classes only on Zoom, didn't have any in-person activities, and her whole class had been vaccinated. And so I think, examples like that are sort of concerning, right? Because it sounds like, well, you're otherwise healthy 23-year-old, you do all your work online. This seems like maybe not the best prioritization situation. And I think that all of this confusion and these diversity of policies is sort of illustrated by a message I got from one student who wrote, and I'll just read this quote. She said, "One of our clinical sites told us that any student with a clinical site badge should come walk in and get a vaccine because they were expiring and would be thrown out this week. Someone told our medical school administration, and we got an email literally saying that the clinical site vaccinating rotating students was a, quote, gift, and that we should not get vaccinated there if we weren't actively rotating there. To top it off, today we learned that our medical school now has a vaccine supply and is actively vaccinating faculty and standardized patients who are mostly online, and they did not notify us. Many students took advantage of the clinical site offering the vaccine and are now afraid of professionalism violations." So I think you can see that, with a lack of central guidance, with unclear policies, what emerges is this poopery of very different policies at different places. Some are better and some are worse. And that sort of suggests the need for better analysis and clearer guidelines. And with that, I will turn it over to Sam, who's going to talk about how we attempted to address this issue.
Great, thanks, Leah. So we have a number of examples that Leah gave us of how it has turned into sort of a free-for-all with different schools having different approaches and policies towards vaccinating students in the health professions. And what we wanted to do is we wanted to see if there was a fair way to decide whether students should be given priority access to vaccines. And so in order to do that, we looked at a number of prominent ethical frameworks to see how they address the question of whether healthcare workers, professional healthcare workers, should get priority for the vaccine. And we thought that healthcare workers were the closest counterparts to students in the health professions. They have a lot of similarity in their exposures and in their activities. And so we wanted to see if healthcare workers were prioritized to receive the vaccine, and then if the reasons given by these frameworks would also apply to students in the health professions, and maybe help us come to some sort of definition of whether healthcare students are more students or more clinicians. And so we looked at 4 frameworks to see a range of views on this question. These are from the WHO, the National Academy of Sciences, the CDC, and one from a number of well-respected bioethicists. And we found that all of these frameworks say that healthcare workers should receive early access to the COVID vaccine, and they largely agreed on the reasons for doing so. And prioritizing these workers for early vaccination was thought to advance 4 key values. So all of the frameworks prioritize healthcare workers because they're at high risk of contracting COVID. They work in clinical settings, and this value is about protecting people who are at the greatest personal risk from the pandemic, exposed to patients who have COVID or unknown COVID status. Second, all of these frameworks prioritize healthcare workers on the grounds that they're at high risk of transmitting COVID to other people. So as part of working in clinical settings, they frequently interact with patients who are sick or at a high risk of morbidity or mortality if they contract COVID. And so it's easy to spread it to many other people who are vulnerable and at risk. So for instance, this would support early vaccination of nursing home staff, just as an example. So the third reason that's given is that healthcare workers are necessary for the continued function of the healthcare system. If too many healthcare workers get COVID and are ill, this could lead to local or national staffing shortages. And so giving them priority for vaccination ensures that the healthcare system will continue to function. And finally, there's a question of reciprocity. And so reciprocity suggests that some healthcare workers are owed early vaccination because of the work they've done in the pandemic on behalf of society. So for instance, some physicians and nurses and respiratory therapists worked in hospitals early in COVID without the proper PPE. They took on a significant amount of risk in order to help society. And reciprocity suggests that they should be prioritized as a sort of thank you, a retroactive thank you for socially valuable actions. And not all of the frameworks acknowledge this principle, and some of the ones that do claim that it should carry less weight than other principles. So that's a brief overview of the values that support vaccinating healthcare workers. And what I'd like to do now is go through how those values apply to students in the health professions. So in terms of personal risk, students have a similar risk of exposure as healthcare workers. When they're on clinical rotations, they interact with patients and healthcare workers of unknown COVID status. They rotate through high acuity services, emergency medicine, trauma surgery, anesthesiology, where it may not be possible to protect them. And the risk of accidental exposure on those services may be significant. There are some protections for students that can decrease this risk. So for instance, students in the past have at some places have not been assigned to work in ICUs that are specific to COVID patients. But in general, students have returned to clinical rotations in the hospital for the most part. And so The second value, the risk to others, is actually relatively high. So again, students who are on rotations can serve as vectors. Part of clinical education is that you have to get exposure to different specialties. And this means that students shift between teams, between units, even between hospitals very frequently. And so students who are sick are liable to spread COVID to other people. And this risk is potentially even greater because students tend to be young. And as the data shows, young people are more likely to be asymptomatic, if I'm correct. And so the third value, when it comes to protecting health systems, healthcare systems could continue to function without students. So vaccinating students early is not essential to the current functioning of the healthcare system, but one thing that we've seen is that it may enhance the long-term function by enabling students to adequately train for their future roles. So what I mean by that is that COVID has already affected education, as Leah said. It's reduced the time that students have for clinical training opportunities. It's affected the range of those opportunities. So for instance, some places don't have students see patients with respiratory complaints, which is a big part of medical training. And it's even, it's altered preparedness for postgraduate work and potentially even altered graduation timelines. So vaccinating students early allows them to participate fully in clinical education. And it mitigates some of the disruption in training that the pandemic has caused. So even though vaccinating students early isn't necessary to preserve healthcare systems right now, it is important for the future function of healthcare systems. So we thought a sort of analogous value applies. And finally, there's reciprocity. As Leah said, most students were pulled from clinical settings early on in the pandemic, so we did not think that that this applied. Most students took on less risk. Some may have a claim to reciprocity on the basis of volunteering or other activities, but this will vary among students, and it's difficult to figure out who it applies to and who it doesn't. So that's a lot of information, and to briefly recap and give our recommendations, there are 4 reasons for prioritizing healthcare workers for early access to COVID vaccination. 2 of these are about risk to self and others, and they clearly apply to students in a clinical setting. And a third about the functioning of health systems applies in similar or an analogous way, we think. And even though the 4th principle, reciprocity, does not support early vaccination, it's usually given less weight. And so based on this, what we recommend is that students who have significant clinical responsibilities should be counted as healthcare workers for the purposes of early COVID vaccination. These students are the ones who are at the greatest risk of contracting COVID, spreading it, and this approach prioritizes the in-person clinical training that is at the core of being a student in the health professions. What this approach does not do is it doesn't prioritize students who do not have clinical responsibilities. So this is often early year students who are in a classroom setting. They don't have the reasons based on risk. And we believe the educational quality drop off between being in a Zoom format for preclinical or classroom learning and being in person is different than the change in educational quality that you might get if you're not able to have some full in-person clinical experiences. So one necessary disclaimer, under this framework, neither of us would have been prioritized for early vaccination of students. So this is not just a self-serving justification. We are both taking time away from our clinical educations to focus on research. I'm on a research year. Leah, she mentioned, is doing her Ph.D., so we would not have counted. So to circle back to what we discussed earlier, the role of students exists along a spectrum. And as students progress through their training, the responsibilities that they have and the responsibilities that others have to them continue to increase. But at a certain point, it's necessary to draw a line in order to count students as healthcare workers in terms of early vaccination or not. And schools have taken a number of different approaches to drawing this line, but we believe that students should be prioritized as healthcare workers to the extent that they are acting as clinicians. So if they're acting as clinicians, if they're accepting the risk that comes with that, if they are at that stage of their education, then they're much more like clinicians than they are students sitting in a classroom. So based on that, we think it's reasonable to treat them as clinicians for vaccination. So what can we learn from this that's relevant to other settings? So a couple points here. We think that our approach is most relevant to other contexts where there is a gradual progression from student to full practitioner. So in educational settings, student teachers need to have practical classroom experience in order to become fully fledged teachers. And our approach would suggest that, student teachers who are at the practicum stage, who are, in a classroom setting, getting their clinical, so to speak, experience should be prioritized for early vaccination. And this is based off of a combination of risk analysis as well as the importance of continuing to educate trainees. Another important takeaway for us was the need for rigorous guidance. As we saw earlier, schools can make mistakes in both directions. They can vaccinate none of the students, but continue to have them work in clinical settings or pull them from important rotations. Or they can vaccinate students who probably don't need to be vaccinated right away, which deprives others of access to the vaccine. And these are real harms associated with how COVID vaccines are allocated in a health education setting. And it's important to have clear standards so that it's not just sort of an ad hoc free-for-all, or that it devolves into other ways that vaccines might be allocated that we think are less ethical, such as first come, first serve, or based off of power and influence. So there are a number of other issues that we can't explore here. One is whether there should be sub-prioritization among clinically involved students based on who is higher risk. Another is whether there should be prioritization among different types of students in the health professions based on the nature of their clinical exposure or the nature of their education. A third is whether students who volunteer to administer the vaccine at vaccine clinics should get priority. And a number of schools have done this, even though it seems to disfavor students who are immunocompromised or have other high-risk medical conditions. And while there are many other issues that this topic brings up, the final one that I'd like to touch on briefly is the question of how to define the role of students in the health professions. And they're in this liminal space between students and clinicians where they're not exactly one, but they're not fully the other. And Leah talked about how some of our earlier work addressed the question of what the right level of clinical involvement was for students early in the pandemic. So sort of also related to this idea of students being partway through their path towards their professional role. And that, as well as the question of early vaccination, are just a couple examples of how important it is to have an accurate understanding of what the proper role is for students who are training for health careers. It helps us get a better sense of what duties students have. It helps us explore the question of when students transition into a professional role and why exactly that is, because a shorthand answer would be to say that that's when they graduate. But a more nuanced approach is that students actually take on many of the activities and responsibilities before they graduate. As well, it also helps us get a better sense of what duties schools have to their students, providing ample opportunities for education, protecting students during that process. And so this work that we've been doing has been a nice opportunity to think about some of these broader implications as well, which we can't answer here, but as always, we appreciate hearing what people have to say in the Q&A. And so on that note, I'd like to stop here and open the floor for questions, but first, a couple thank yous. So thank you to David Miller, our co-author. Thank you to Haley Sullivan, Sophie Gibert, Nico Adamstein, and Emma Pierson for feedback on this work. Thank you to Robert for inviting us to speak, UNO for hosting this event, and thank you to you, the audience, for listening to our talk.
All right. So We're in Q&A now. I'd like to remind everyone that the Q&A is open and we are very excited for your questions. I see a couple of good ones already and I'm excited by that, but I am gonna exercise my prerogative as moderator and ask some of my own questions first. As I do that, we of course would be happy to see more questions come in too. So first, I just want to say thank you for coming and talking to us. In cases like the one you talk about, where students sort of blend continuously into healthcare professionals, it can be really hard to draw satisfying lines. And yet we do need to draw lines, and it's really important that we get it right here. So you really had a task cut out for you, and I appreciate you valiantly stepping into the breach to do it. It's a hard thing to do, and I think that your proposal seems quite reasonable and has a lot to recommend it. That being said, now let me put on my little devil hat and push back a bit. So out of the 4 reasons that you mentioned for prioritizing healthcare workers, the 2 that apply most to medical students or health profession students more broadly is that they're at personal risk and also that they put others at risk by potentially transmitting it forward. The ones that apply less are reciprocity, which probably doesn't apply, but maybe that's okay because it's not that important a value anyway. We can get into that more later. And also their value to the health system, which you point out they do have value, because if all of our physicians in the future are poorly trained, that's very bad. But they don't have the value that doctors have, where we need people treating people with COVID right now, or they'll all die and it'll be a catastrophe and the whole system will fall apart. It's not that kind of value. If most of the justificatory work, though, is being done by the personal risk and risk of spread, then it seems to me like it really matters the comparative claim versus other populations. You just have to start looking at all the populations and ordering their personal risk and their risk of spread. And so I just wondered, so in Nebraska's vaccine allocation scheme, healthcare workers come first, and then after healthcare workers, but before the general population, come homeless shelter staff, corrections staff, educators, grocery store workers, food processing workers, which have had significant outbreaks here because they work in really close quarters with one another. So they're both at high risk and at high risk of spreading to others. And so I just wondered how you would rank health profession students relative to these other vulnerable groups that cause spread. And both, not necessarily because, I mean, that probably varies on a lot of local factors. That's why different states have different plans, but how you would think about that comparative question, I guess.
Yeah, I think that's a really good question. And I think that these are exactly the kinds of questions we should be asking. I think, so your general point is well taken, which is that, you know, in allocating limited vaccines, we need to be thinking about the risk of all of these groups, both their personal risk and their risk of spread. I think the case for prioritizing healthcare workers, for example, above grocery store workers or other people who are working in settings where, you know, they're interacting with a lot of people, is that healthcare workers are generally working with people who, if they get sick, so if they get COVID, the outcomes may be very, very bad, right? We know that, you know, among people with pre-existing conditions, among hospitalized patients, among people who live in nursing homes, getting COVID is really a bad thing to have happen to you. And so I think, you know, part of the justification of this, of prioritizing healthcare students is that, let's say a healthcare student gets COVID and they transmit it to someone else. That person who they transmit it to is likely to be a person who may have a very bad outcome from getting COVID, which may not be the case for someone working in a grocery store where, you know, they could get COVID and they could transmit it to someone else. But that person, by virtue of the fact that they're in a grocery store, is likely not, you know, bedbound and super, super sick. So I think, you know, when we're thinking about this issue of personal risk and risk of spread, there's also this question of like, okay, what bad things are going to happen if the spread occurs? And I think that that's part of the justification for prioritizing students who are working in these contexts with these very, very vulnerable patients who, if they get sick, they very well may die.
That seems also very sensible. And yeah, of course, you have to weight it based on not just the risk of spread, but the expected impact of spread. How many DALYs or how many QALYs are you losing out of each case of spread? What's the expected outcome for people who are familiar with that jargon? Just a fancy way of saying how bad is it going to be. Okay, so sort of related to this, there are two questions from the Q&A. And this, I think, both come down to dividing lines among students and different types of students once we're focusing on these factors. So one is, how do you determine where the line should be drawn between those who are students not participating in clinical trials and those who are sitting in a classroom? Is there a bright line between those groups? Do sometimes people do like a little bit of clinical work, but like not too much? And sometimes people do a lot. And so then like, how does that shake out into a division?
It's a great question. And so thank you to the chat for bringing that up. And it's absolutely spot on, because there are schools where, for instance, early year students have some, outpatient clinical education, and that's been put on pause because of COVID. And should they be prioritized in getting back to that, for instance? And so I think there, it's the framework that we go through is sort of a rough guideline for thinking about the factors that are important here. So it's not going to be possible to draw a clear, bright line that, only all medical students are either clinical or non-clinical, all nursing students are either clinical or non-clinical. But it focuses our attention on thinking about the value of what does this educational experience mean to this student at their current point of training, and what are the risks associated with getting them back into that clinical experience, months ahead of where they might be otherwise, right? And so if we're talking about a first year student who's having a once a week, half day outpatient clinical experience, the educational value of that and the risk to people who are coming into an outpatient office are different than the value to students of being able to do intensive care rotations, or rotations where they're working with patients on ventilators, and the risks to patients are significantly higher, and the educational costs of missing out on those rotations are significantly higher. And so it's absolutely true that there is no bright line, but I think this framework helps to focus our attention on how to think about where to draw some of those fuzzy lines in practice.
I think it's also worth noting that the sort of framework that you produced and the sort of like bioethical document that is, it's designed for national consumption and to give broad guiding values, because you couldn't say, you're not familiar with exactly how every student at every school trains in every different state and every different like sub-healthcare field, right? So you're not going to be saying, Mindy over here gets the vaccine and John doesn't, right? You're trying to articulate values that then institutions can take up themselves and use to guide their more informed and more specific deliberations. So there's going to be a limit to Mindy and John, but while we're at it, and because it's a particularly interesting class of people, I'm particularly interested in this class of people, where would you place yourself in the vaccination timeline? Asked someone from the Q&A. Healthcare workers are still being vaccinated in some areas, and certain healthcare workers were vaccinated prior to others, such as emergency department staff and COVID floor staff, before med-surg floor staff and regular ICU staff. Would you be synonymous with healthcare staff or after healthcare staff?
Well, I'll let Sam take that for himself too, but I would just say, so I'm a PhD student. I'm doing my classes via Zoom. So I would place myself like maybe literally last, like 330 millionth in line because I'm at super, super low risk. I mean, I can literally leave my house never. And I just think that there's many millions of people who are at higher risk than me by virtue of their age, by virtue of their work, by virtue of where they live. There are lots of things that protect me. What I can say is that I've signed up actually to volunteer at COVID vaccination clinics, as have many medical students. And if I were to get called to do that, then I think the equation changes somewhat, right? If I were going to be working at a clinic and seeing, potentially dozens and dozens of people every day, many of whom right now are, older people, vulnerable people, I think that there would potentially be an argument for me to then get vaccinated, sort of to protect the people who I would be working with in that healthcare setting. So that's been my thinking so far.
I'm on a research year for the most part. And as someone who is, doing research from home, my prioritization for the vaccine would be very, very low, sort of in line with what Leah had said. But one thing that makes this a little more tricky in my situation is that I'm actually going back to do clinical rotations in the hospital starting next month. And I'll be on a rotation where, a large part of it involves procedures such as bronchoscopy or intubation, where you are directly in front of someone's face, and where I'll be working in large part with patients who are immunocompromised because they have, in particular, cancer because of the hospital where I'm doing this rotation. And so I would say that that's sort of an instance where I think that for the purposes of vaccination, I think that med students should be treated more like clinicians, and where I think it's actually really useful that you see this sort of difference in how we might be prioritized for vaccination based on the activities that we're doing at the time.
Thank you for that. This is also yet another related question from the chat. So I like the justification that students should be prioritized for vaccination to the extent that they act as healthcare workers. However, should schools find creative ways to train students adequately while also reducing the degree to which they're exposed to COVID and the degree to which they function as healthcare workers in order to justify vaccinating them later? For instance, place students on low risk and online rotations for a few months while healthcare workers get vaccinated first. It seems like the public health goal could be achieved either by vaccinating students or by minimizing the risk of them transmitting COVID.
Yeah, I think that's right. I think that's a really good idea. And I think at some places schools are doing this. So, we talked about earlier how in early phases of clinical education, like, in first year of nursing school or medical school, students may work with patients in outpatient primary care settings. And I think a lot of that can be done via telemedicine, right? So, a lot of primary care providers now are seeing their patients, via medical Zoom. And I think that students can participate in those kinds of visits as well and gain a lot from that experience. And they don't necessarily have to be doing all of those activities in person. I think this gets harder when you have more advanced students who are, if you got a fourth year medical student, next year they're going to be a doctor and they're going to be taking care of patients. And so if they're applying into ear, nose, and throat residency, where they're going to be doing ear, nose, and throat surgery, it's important to get them seeing those patients now, getting them, observing those surgeries, learning about the guidelines for care. And so I think you're right that to the extent that you can do this without compromising the quality of education, you should. I think that, this becomes tricky for students who are in more advanced stages of their education, where they may be about to head into a field where they're actually going to be providing care to patients. And it's important for them to get that exposure now.
Sam, you're on the same page?
I think that's a great answer. Yeah. Yep.
Yeah. I mean, also, so for students who are very late in their education, right, if everyone's agreed that we're going to vaccinate doctors first, or healthcare professionals more broadly, so that's really the class, what would be the point? I mean, if you make them wait 2 months until they then become a doctor to get vaccinated, that's not like a whole bunch of extra vaccine time you've secured for someone else. They're still going to need the dose in 2 months when they go out to practice. So don't you want them to go out and practice well? That seems like that's a trade-off that just, as they get closer to the end of their education, it becomes more and more important for them to have the clinical training. And also they're gonna need a dose super soon anyway. So moving it forward a little bit seems pretty easy to justify, to me at least. At least I would want to lean on that.
I think also one of the interesting things that this brings up is, I mean, schools have done this. They have come up with creative ways to, as we've been talking about, prioritize students who are sort of later year for the in-person clinical experiences, and find creative ways to teach early year students. And so it, you know, in online or Zoom formats or in like hybrid formats. And so it's kind of been an interesting laboratory for a lot of educational work about, you know, sort of reimagining some of the health careers education that's gone on. And obviously, you know, this is a time where there are a lot of things up in the air, but there's been some real creative approaches to re-envisioning what early year education looks like.
I mean, health education and health practice, right? And of that, we're doing all this telemedicine now partially because of risk, but maybe something we're going to discover is that there's stuff you can just do over telemedicine. It doesn't need to go back at the end, right? And so, and then that's also relevant to how we train the people who are going to be doing things going forward. So I do, since I sort of promised that we might touch on this, there's one question from the chat I want to get to, which is, can you please speak a bit more about the value of reciprocity and whether you think decisions should be made on its basis? Since you guys kind of booed it a little bit, I made a little passing remark about that. Explain to me why most frameworks don't put a high value on it, and also what you think about it.
So the way I think about reciprocity is as part of this sort of twofold approach to instrumental value, right? So there's retroactive instrumental value. So society is saying, you know, vaccinating people as a thank you for things they have done in the past. And then there's sort of forward-looking, so, you know, vaccinating people who are going to be instrumental in the future. And why I think some of these, frameworks are less supportive of reciprocity is that in some cases it's hard to determine what counts as absolutely essential, although there is definitely a case to be made that professional healthcare workers in a pandemic should, you know, are sort of the definition of essential and should be counted. Another is that it's, how do I put this? It's hard to say, it's hard to define individual contributions. So it's hard to say, you know, this is where we draw the line of people who get sort of retroactive reciprocity sort of thank you and people who don't. I don't know, Leah, do you have some other thoughts on this one?
Yeah, I mean, I would say another important thing to consider is that reciprocity can be doled out in a lot of different ways, and it has been. So at a lot of medical centers, they've been giving sort of tokens of appreciation to healthcare workers, ranging from like a mug to like thousands of dollar bonuses. I like maybe don't do the mug, but the point is that you don't have to just give out reciprocity in the form of a very highly limited vaccine dose. And so to the extent that you can do this with like less limited resources, then maybe you should do that instead. So I think that's one thing. And I think the second thing is that, you know, reciprocity is good, right? Like, you know, if someone does something nice for you, it's good to do something back for them. Like, we can all agree with that. But I think the trade-off that we're making here is that people who don't get vaccines may die. And so the question is, you know, is reciprocity important enough that we're going to accept that sacrifice in order to ensure reciprocity in this case? And I think my answer to that is it just isn't important enough to justify people dying as a result of fully fulfilling this value of reciprocity. And that combined with this issue of, you can give out reciprocity in financial ways or in other sorts of ways. I think it just doesn't provide a compelling enough justification to make that a foremost value in allocating these limited vaccines.
I would also, and you can maybe push back on this if you'd like to or not, maybe you'd have an interest in pushing back on it. So I would also suggest at least a concern, as you mentioned, reciprocity can be realized in all sorts of different ways. People can be thanked and appreciated in all sorts of different ways. And doctors are generally very well thanked and appreciated in our society. They command tremendous amounts of social respect and they get paid lots. I mean, it varies depending on your specialty and everything. And definitely that doesn't necessarily apply to all healthcare workers, but doctors in particular command enormous amounts of respect and compensation. And so you might think that they're already pretty well thanked for a job which includes in its nature that they're going to sometimes expose themselves to risks like this. Like, I think it's a traditional view of the ethics of the medical profession, right? That the doctor, by agreeing to become a doctor in times of non-plague, takes on some level of obligation not to just quit the field as soon as a plague comes around. Like, that's part of the deal. That's part of why you get to be so respected and rich, is because sometimes there's going to be COVID and you're going to have to be on the ward. So that's not exactly like a rigorous 17 premise argument about fairness, but that's some polemical remarks that suggest that perhaps we don't need to worry too much about reciprocity in this context.
No, I think that's completely right. I mean, I think there's many types of workers who were at very high risk at the beginning of the pandemic. We're working largely thanklessly in jobs that don't pay very well under conditions that were exploitative and unfair. And, in terms of reciprocity, I mean, doctors were very appreciated as a general profession, and a lot of these other workers aren't. And so I think, yeah, this sort of exceptionalism of how we apply reciprocity to healthcare workers, I think is wrong. And so maybe if you were actually going to implement it equally across all these types of professions, the question would be different. But I think this idea that doctors and nurses are somehow special and get some sort of special reciprocity, I think that just doesn't really hold up under scrutiny.
All right. So probably we have time for one last one before I'll close up. So the line that's drawn between priority student and not priority student appears to be blurry and malleable. Will this line fluctuate with new developments in vaccine rollout? What ethical issues do you see being born out of the potential for it to change over time? How can we mitigate them? So, I mean,
yeah, I can take a stab at this. I mean, yes, you're right. The line is blurry and malleable. And I think that, partly this is going to depend on how many doses we have, right? If we have 200 million doses, the question of who to prioritize is different than if we have 2 million doses, And so I think that the line is going to move sort of depending on what the availability of vaccines is. So yeah, to your point of does this fluctuate with developments in vaccine rollout? Yes, it does. I agree. What ethical issues do we see being born out of this potential fluctuation? I mean, I think what we've seen in existing policies already sort of illustrates this, right? Which is that a lot of these healthcare centers are going to ask for a lot of vaccines, and they're going to try to give them to everyone they can give them to. And so I think policymakers have to really be rigorous in sort of scrutinizing how many doses are actually needed and who these doses are being administered to. Because I think, there was a really good New York Times article about this if you want to read about, the elite medical centers slide we had. Basically at a lot of places, they were just given, tens of thousands of doses, and they were vaccinating grad students who were fully online. They were vaccinating, admins who were fully online. It was like everyone and their mother was getting vaccinated. And so I think that as we continue to think through this, recognizing that everyone's under a ton of pressure and people are doing their best to make these decisions correctly, I think we need to really be scrupulous in making sure that the correct amount of doses are allocated to the correct parties at the right time.
So, question: do you think that once a medical, this is back to me. Do you think that once someone does get vaccinated, they're now morally obligated to continue carrying out high-risk work? Like, if you're vaccinated because you do stuff in the ICU, now you're like, by accepting the vaccination, you commit yourself to staying in the ICU and continuing to work there, at least for the duration of the pandemic.
I would say absolutely. I think, like, to the extent that healthcare workers are prioritized for, because they're at high risk, or because they're vital to the functioning of the healthcare system, I mean, it makes sense to continue to further those values. I mean, the risk-based reasons are about protecting, healthcare workers, the people they interact with, but the functioning of the healthcare system it's really a societal investment, right? And so, it's reciprocity being backwards looking, but preserving the function of the healthcare system is something that's sort of implicitly or really explicitly asked of people who are given priority, saying, you are sort of important enough in this role that you're going to be bumped to the front of the line, and so we're depending on you. And I mean, until the end of the pandemic, right? Is there a point where those workers become like less than fully essential because there are more available resources? Sure. But I think they do commit to staying in the role that allowed them to get prioritized to a certain extent.
Yeah, I think that's right. I just want to just add one small point, which is, to the extent that people are able, right? If I think there's been a ton of burnout, a ton of mental health issues around these workers. And so, of course, if people are really struggling, they should take the time they need to get the care they need.
So, great answers. Thank you so much for coming and speaking to us today. It's been wonderful having both of you. It's been a privilege. Thank you also to the audience for tuning in. If you enjoyed the talk, I'd like to remind you that first off, this is one of a series. So the last Thursday of every month at 7 p.m., we'll be hosting an event like this. There will be links to the other events in the series in an email that you will get if you registered, which you have registered because you're here. Similarly, there will be a recording. The recording will be made available to you as well as everyone else who registered but wasn't able to join us live, so you will be able to consult it later if you'd like. Our topic next time will be fairness in algorithms used for medical triage. We will be hosting Dr. Ben Schwan, and very excited to have him, and hopefully some of you will be able to join us. But we are just about out of time. Our time ends at 8, so thank you so much, everyone. If you two want to sign off, you're welcome to.
Yeah, no, thank you guys so much for coming and for asking such good questions. We really appreciate just the opportunity to have this conversation. And of course, if you have any other thoughts you want to share with us, feel free to reach out. We're both on Twitter. We have LinkedIn. You can find us. So thank you guys all for coming.
Thank you.